Good afternoon, everybody, and welcome to our session on innovations in primary care. What we are going to do is we're going to have everybody do their presentations and then leave time for questions and answers at the end. And the first thing that I just want to throw out a challenge to our speakers and make sure that as they present their innovations, they, somewhere in their slides or at the very beginning, give us a very brief 1-minute context of what's happening in primary care in their countries, so that we have a context to understand the innovations. And we're starting with Sarah Morsink. You can see who she is. If she wants to say something about herself, she can, but you've got everything on your app.
Thank you. So I'm Sarah Morsink, and I work at the federal government of Belgium. And I'm very happy to talk to you about today about the mental health part in integrated care. A lot of my presentation is also applicable on healthcare in general, somatic, social, and so on. But I'm very happy to highlight the mental health part, as it feels that sometimes it gets a little bit lost in translation. And I'll be talking about the primary psychological care offer that the Belgian government has decided to implement nationwide, the reimbursement of this type of care. And spoiler alert, I don't have a lot of time, so I'll be focusing on some observations to illustrate the vision behind the project. Then I'll be very, very brief on the project itself and focus more on the lessons learned, as that is, for me, the most important part. All right, so very quick, I'm going to walk you through some of the observations. And first of all, it's about that health is a lot more than just the absence of symptoms. It's a state of thriving. And you also see this in the prevalence of mental health problems, where a lot of people don't have any problems. Yay, that's very good. A relatively large group has mild to moderate problems, so they don't feel well, but it's not to the extent that they cannot function anymore. Then a relatively smaller percentage has really these severe chronic acute problems. A third observation is that ill health has obviously a cost on the individual and his context, but also on the society as a whole. And ill health is, of course, multifactorial. So that means that all the time, mental health, especially mild problems, go together with somatic problems, feelings of stress, tension in the muscles, headaches, sleep deprivation, and so on. So, of course, and I'm not telling anything new, I guess, all these things come together in public health, where we focus on the whole population and try to provide an offer that's very efficient and adapted to all these different kinds of groups. But this means that for mental health and psychological care, you don't only focus on interventions that have the goal of remediation of severe problems of psychiatric disorders, but also on prevention, early intervention, and early detection. So the whole spectrum of interventions are taken into account. And another way of looking at it is that our offer of mental health has to be aligned with the prevalence of mental health problems. So this means that a relatively larger amount of services have to be there for people with mild to moderate problems, and a relatively smaller, equally important, but a relatively smaller amount, quantity, not quality, has to be allocated to these intensive, long-term residential treatments. Now, in Belgium, and I think a lot of countries are the same, this triangle is reversed. So there is a lot more attention, a lot of more resources allocated to this intensive treatment and not to primary care, which is a very logical reflex both on the level of the policy making, but also on the clinical level, to really want to support, if you have limited resources, to support those who are in more need, more severe problems. But actually, it puts us as a society in a very uncomfortable position where people with mild problems do not get their needs met. So either they have to wait until their problems escalate before they can find help, Or they go and find help, they reach out, but they have a too intensive offer, overshooting of what they really need. Both these things make sure that we have an enormous pressure on second-line services, something we all face today in a lot of countries. And above that, we see that the step to care is very difficult for people. And this is not only because it's often not reimbursed, psychological care or mental health care. Also, stigmatization plays a little part, but the biggest problem where people have difficulties in finding care, in really making that effort, that step, is because they don't know they have a problem. That's mental health illiteracy. They think, I'm not crazy, I'm not a psychiatric patient, I'm not feeling well, but I'm not like that. And second of all, they don't know where they can find help, and it's caused also by the polarization of our care, of our health care and mental health care, where they go to a general practitioner if they feel stress in their body, in tension in their muscles, but they don't go to a psychologist who is 3 houses down the road. Now, this is a part in the presentation where things get worse before they get better, but they will get better, I can assure you. So this observation is even worse for people who have vulnerabilities, children, adolescents, elderly people, people with different migration backgrounds. For them, the step to care is even more difficult. So we have the obligation to focus also on those groups, to give them an advantage, to give them the same chance to have their needs met. Now, all of these observations, they make for a joint policy agreement that was agreed upon by all governments of Belgium, and we have a lot, to really have a coordinated approach to strengthen psychological care in primary care. So this is part of the mental health reforms in Belgium. Unfortunately, I don't have a lot of time to talk about that, but it's really interesting too. And really the base is the networks that you have. We call them mental health networks, or also health and well-being networks in Belgium, that are partners, local partners that partner up together and implement policy in mental health, but beyond health and well-being as well in their local area. So what we reimburse are 2 psychological functions, focus on prevention, early intervention, and detection. I'm not going to tell you more about that, but we also value the expertise of others. And there's one thing I want to focus on. We really use the population management approach, where these networks get the budget allocated, that they stratify with vulnerability indicators. They see what offer they already have, they see what needs there are in their little area, or in their area, and what they can do with the means that are allocated. And they ensure with this an integration of care, intersectoral and multidisciplinary. And unfortunately, I don't know the English translation. If anybody knows it, please help me. So I called it context-embedded and outreaching care. In Dutch, it's vindplaatsgericht werken. I think it's so new and innovative that there's not really a translation for it, not that I know. And that's you're really gonna put a psychologist in the same building, in the same room as a general practitioner, that you take the psychologist in the classroom into a community care area, in areas that are not mental health related, not stigmatized, but where people are already for hobbies, work, school, and so on, to make this step as small as possible. So the first evaluation is that we're running on a good speed. We have 7 million each month that's used to reimburse this kind of care, and it's augmenting every week. We are able to produce significant positive results on symptom reduction, on absenteeism, which is good for, of course, the society. We are able to reach vulnerable people that were not in care before. We have a lot of patients that have problems that are too severe, so not mild to moderate, but more moderate to severe. But still, for them, this kind of care also works. We are able to stimulate integration in sectors and multidisciplinary. We do meet quintuple aim as a whole, so I think we can be very proud of that. And reasons why, the lessons we learned is that you need this kind of networks, these partnerships to organize care. It's the only way to organize demand-driven care, because if you give a budget to one organization, it's always going to reinforce their own services. So you need to give this in a demand-driven way. You need also the meso level or intermediate level of this network also to provide care for very mild problems. You need this stratification of budget. You need this communication campaigns. You need this reflection, population management on this meso-intermediate level to have effect on the local level. You need also on the federal level a team that can coordinate this. I'm just gonna see what else I wrote there. Yeah, so you need this function, we call it local coordinator, to really help support this on the local level. Are we there yet? Not at all. Change management takes a lot of time. We had a lot of resistance, a lot of mistrust by psychologists, other actors, even people from our own organization. But we kept on going, and it's the only right way to go. I think we just need to start with the early adopters, offer a training program, and I think I have to be very fast for the last part. We need to focus on a pathway to our public mental health goals instead of the goals itself. It takes time. We go further when we're together. We go faster when you're alone, but we go further when you go together. I think that's the key message that I want to give here. And it can work. It just needs time. It needs this change management. We also share with a lot of other countries our experience, so feel free if you have questions or want more things in detail to ask me. And next year, we're going to optimize our offer for the following years to come. So thank you for your attention, and I'm going to pass, I think, the microphone to the next speaker. Thank you.
Thank you very much, Sarah. Just to say, because we were at the beginning with these technical problems, that we are leaving the, we're not doing the bio description. You've got that in the app. You can go there and read everything. We are getting all the questions at the end. And just to say, we are sitting over there because they can see us. We are being extremely tough in terms of the time. And it's because we want to leave time at the end to have discussions, right? So we are now moving to the Basque Country, and Alvaro is going to introduce us. Please, Alvaro.
Okay, thank you. Good afternoon. I am Alvaro Sanchez from the Primary Care Research Unit of Vizcaya in the Basque Country in Osakidetza healthcare system, and I'm here to present the following presentation. How it goes. ¿Cómo van las diapositivas? ¿This one? ¿Cómo van las diapositivas? Perdona. ¿Con el verde? ¿En este? ¿No? Ah, vale. Ahora. Okay. The aging of the population and the increased diagnosis and control of pathologies together with the demands of today's society for a greater accessibility to services as one of the dimensions of quality have led to a significant increase in the demand for healthcare in recent years. The insurgence of the COVID-19 pandemic has further exacerbated the overload on accessibility to health services worldwide. It is known that the use of information and communication technologies in the process of citizens' accessibility and citation to the health services can contribute to both alleviating and properly organizing demand and increasing user satisfaction. That is why, since 2006, Osakidetza has been offering an internet appointment service for citizens to make face-to-face or telephone appointments with a primary care physician, pediatricians, nurses, or other professionals. The system is accessible from mobile devices, desktop computers, and by telephone through a voice recognition system. However, the option that the patient chooses the appointment taking into account the type of professional who will provide the care may not always be the most appropriate system to get the care that he/she really requires. For this reason, in 2019, with the implementation of a strategy for primary care in the Basque Country, an appointment model focused on demand management is proposed, more oriented to manage the appointment according to the reason why the citizen wishes to contact Osakidetza. However, this web appointment application used so far in Osakidetza does not adapt to this demand management model, and therefore the Directorate of Osakidetza has been working on these last years in order to adapt and implement a new web appointment tool fully in line with the corporate demand management approach. The goal of the presentation is to describe the process through which the web appointment app based on the demand management model was designed and implemented, and to show some results of the evaluation of the perceived satisfaction and usefulness by users of the app during the 2 initial implementation pilots. So how we did it? You can see here in the slide the steps that has been carried out. So a formative study was carried out with a multidisciplinary working group made up of professionals from the Subdirectorate of Coordination of Primary Care, Subdirectorate of ICT's Department, and Subdirectorate of the Quality and Information Systems for the design and development of this new web appointment tool. It was pretended to design this new tool in line with this existing face-to-face and telephone appointment system, but now organizing the appointment systems according to the reason for consultation, and then the most appropriate professional to resolve this consultation or the problem that the patient is facing. A multi-phase implementation was proposed, which will allow piloting the solution within the expected deadlines and facilitate the resolution of possible incidents that may arise. So there was first phase 1, in which the functional analysis of the new web appointment tool needs were taken into account, also the development and integration of this new IT tool. A phase 2, with an initial 10-day pilot in a highly controlled environment limited to 1 primary care unit per historical territory, including the evaluation of perceived satisfaction and usefulness in a selected sample of 196 users, and also recording all the incidents that occur. A phase 3, carrying out the necessary readjustments and solving all the detected incidences, and phase 4, a stepwise deployment in all Osakidetza service organizations of the updated version of the tool, including a second evaluation of satisfaction and usefulness in a new random sample of 254 patients. So now here in these slides you can check how it works. There's a first level that displays the reason for consultation. You can see there's a group of administrative acts, also health issues, and it has been also performed to manage the COVID-19 pandemic. The second level, it groups and shows and displays the possible grouping of administrative acts or grouping of health issues, and a third level in which all these grouped administrative acts or health issues can be specified, so the patient or the user can select the one that is looking for. This is a display of an example of the flow of the appointment tool related to health issues. You can see several wound care, disease, chronic disease, health promotion, and so on, wound health, pediatricians. And this is how actually really look the app, so when the patient navigates in the web in order to select the appointment. So the results of the first pilot, it was a total of 6,000 appointments were taken through the web, of which 1,500 was related to face-to-face appointments, and 4,400 almost was related to telephone appointments. More than 80% of the people surveyed considered that a new web appointment application to be simple and easy to use, enabled them to get the appointment they needed. And the main incidents that occurred were related to the adaptation of the appointment model, the referral flows to the new administrative agendas, and errors in the configuration of those agendas, and other minor technical incidents. There was also a second pilot after having done the adjustments, where 326,000 appointments were made through the web, of which 113,000 were related to face-to-face appointments, and the rest, 212,000, were related to telephone appointments. In this case, 77% of the respondents reported that they found the tool easy to use and useful, and 75% confirmed that they got an appointment that they needed. But the most important finding, I think, it was that we have increased, as you can see in the right top of the slide, the appointments related to administrative acts, and so have we done with the acts rolled by nursery. So this means that we have reduced inappropriate appointments with family physicians, as for example, those related to administrative issues or those related to minor health problems. So this is all the presentation, and thank you for your attention.
Thank you very much, Alvaro. We asked the presenters to say something about the situation of primary care in their countries, and they are forgetting, so we'll come back to that, and I'm going to be asking you to say something, because we have to put this in the context of the huge sheer challenges that primary care are having in, or are facing in all the countries around the world. So this is something that we'll come back to this later, and this presentation, I think, is very good. So next presenter is going to be Indira, and you are from here, from Flanders, so you are going to present about the implementation of interprofessional pharmaceutical care initiatives. The presentation is up, I think? Yes? Please, go ahead. Thank you.
Thank you. Hello, everyone. My name is Indira Coenen. I'm a PhD researcher at KU Leuven, and the topic of my presentation is interprofessional pharmaceutical care initiatives. Yeah. Deze. Deze. Okay. Yeah, thank you. So I'm going to start again. The topic of this presentation is interprofessional pharmaceutical care initiatives for older people with polypharmacy. My name is Indira Coenen. I'm a pharmacist and PhD researcher at KU Leuven, and together with my colleagues, we identified lessons learned from successful bottom-up initiatives in primary care. We have to face it. The topic elderly care is very often framed in a negative way in Belgium. People are living longer, thanks in part to the development of better medications. But the downside of this is that people are developing more chronic illnesses, requiring them to take more medications. And taking 5 or more medications a day is the most commonly used definition of polypharmacy. Pharmaceutical care for polypharmacy patients is very often complex and challenging. Interprofessional collaboration plays a crucial role in the quality of care for these patients. It occurs when the different healthcare professionals apply their unique skills and knowledge to obtain the patient goals. So, although there is evidence that an interprofessional approach is important for the quality of care, this way of working is often not implemented in daily practice. Therefore, the aim of this study is to identify successful, already implemented initiatives in primary care for older people with polypharmacy. And we aimed to identify the characteristics of these interventions, factors influencing their implementation, and experiences from older people. We used a qualitative design with semi-structured interviews, and we interviewed primary healthcare professionals and older people involved in these initiatives. An inductive analysis was performed to identify main topics. And this table provides an overview of the 9 different initiatives that were included, we interviewed in total 15 healthcare professionals, and there were 5 initiatives situated in the ambulatory healthcare setting and 4 in the nursing home setting. In all initiatives, there were interprofessional consultations about the medication plan of older people. And I will give you now an overview of the factors influencing implementation of the initiatives. In the center of the figure, we positioned the intervention or the interprofessional initiative. And the factors that surround the intervention or unique circumstances are defined as the context. The context can be defined in 3 different levels: the micro, meso, and macro context. Then implementation strategies are actions to enhance implementation. These can be divided into 3 themes: the communication and influence, coordination, and incentives. But I will now first focus on context factors. The first one is a micro context. And in the micro context, the personal attitude of the different healthcare professionals and the personal relations seem to be key factors. An open, enthusiastic attitude facilitated the interprofessional collaboration. And in contrast, resistance to change was frequently observed and hindered collaboration. Interpersonal relations are very important influencing factors. Face-to-face interactions and transparency on the different healthcare professionals' roles are important to build trust between the healthcare professionals. In contrast, a high staff turnover was a hindering factor for the interprofessional collaboration. Then in the meso context, we identified 3 themes. The first one is the scale of the initiative. A small-scaled initiative with close collaboration between healthcare professionals works best. Then a culture of collaboration and intervision. It was mentioned that housing these different disciplines into one building was not a sufficient condition for interprofessional collaboration. If there was no culture of intervision, the healthcare professionals worked separately from each other. And the last one, time creates opportunity. When the initiative was not implemented in daily practice, it was considered as an extra task on top of daily practice, and a high workload was identified as an important barrier for the implementation. Then the macro context. The political context is of course important. So when you have a legal framework that provides transparency on the different healthcare professionals' roles and on the medical fees that are provided, are important facilitators. Then the ICT possibilities and sharing electronic data of patients in a secure manner is important for the collaboration. But at this moment, the ICT possibilities are restricted, according to the participants. And especially in the nursing home setting, there is a lack of an integrated file, so that hindered collaboration. Then I will discuss the implementation strategies. First one is communication and influence. An open communication with all stakeholders was an important facilitator of the implementation. And all initiatives originated from a need that healthcare professionals experienced in practice. So there was co-creation of the initiative. Then the coordination. An initially well-structured initiative was important, and then a gradual implementation of the initiative. So a step-by-step approach worked best. Education was important to get all noses in the same direction, so to align all healthcare professionals. And then leadership. In most initiatives, there was a project coordinator, but it was mentioned that it is important for the sustainability of the project that the healthcare professionals become self-directed. And continuity of care, as previously mentioned, it's important to have a fixed point of contact. So when there's a high staff turnover, it's more difficult to have a cohesion between the team members. And the last implementation strategy is incentives. So funding is important to test workflows in pilot projects, but there was a great concern of the long-term funding of most projects, so this resulted in doubts about the sustainability. And additionally, a small financial incentive can provide some form of appreciation of the care provided of the healthcare professionals. The positive effects of the initiative were also motivators, so revealing intermediate results or appreciation of the patients were enablers for the initiative. And the last one is increased job satisfaction. So healthcare professionals had a positive feeling of belonging to a team. And moreover, sharing responsibilities caused a reduce in stress, so this resulted in increased job satisfaction. Then in conclusion, if you want to set up a successful interprofessional initiative, use a bottom-up design, choose your project coordinator wisely, make teammate decisions with a shared responsibility. Patient involvement in the medication plan is very important to get to know what their needs are. And for political colleagues here in the audience, long-term funding is important for the sustainability of this pilot project. Thank you for your attention.
Thank you very much, Indira. Well, the room is fantastic and, you know, it's great, but the difficulty or the challenge is that we have to go down and up all the time, so I'm going to lose weight in this hour and a half. Thank you very much. It's very interesting. By the way, if we are running our annual survey, this time is about coordination and continuity of care. So if there is people in the room who haven't voted and participated in the survey, I encourage you to go to the IFIC website and you see there an invitation to vote, because it's asking about what does coordination and continuity of care mean to you. And now we're moving to we're moving to Scotland now, and our next presenter is going to talk, Anna is going to talk about a novel partnership for proactive person-centered anticipatory care in North Lanarkshire. And you're presenting, right? Fantastic, very good. Yes.
Which button did I press?
Yeah, is the just big one. Yeah, the big one, yeah. Let's see if it moves the slides. Fantastic, there you go.
Thank you.
Oh,
Hi, my name is Lisa, and it's a pleasure to be with you all this afternoon. So we're here today to talk about the Living Well in the Community project that was established in 2019. But to begin with, let's set the scene. So as you can see, this is a map of Scotland. The most dense area of light, that's the Central Belt. And within the Central Belt is North Lanarkshire, the area that we currently practice. So North Lanarkshire is an area of high deprivation and people living in poor health. But we also have the lowest number of GPs in Scotland. So in 2020, as we all know, COVID hit, and all non-essential services halted, and that included this service. However, at the time, there was a real recognition of the huge negative impact that COVID had had on the most vulnerable members of our society, particularly older adults. So as Churchill said, never let a good crisis go to waste. So despite being in the middle of a global pandemic, the GPs had a desire to restart the project. And a pivotal moment occurred when Brenda and Anna met. Anna shared her frustrations at the lack of resources, but the desire to restart. And Brenda met that with, "We can help." So we drew on the skills and the resources that we already had available to us, and we developed a three-step approach. Firstly, the GPs would identify a person living in their home with escalating frailty. Secondly, an advocacy worker would visit the person at home and support them to complete a guided self-assessment of their needs. And then thirdly, all members of the MDT would meet on Teams to discuss the home assessment and what was needed. By having an advocate involved throughout the whole process, ensured that the person's views and wishes were heard at all times. We're going to see a short film, and in this film you're going to meet Tom and his wider family, and they're going to explain in their own words the impact this project had. If I can get it to play.
So Equals Advocacy basically explained to me that I wouldn't really need to be dealing with individual people like the nurses, the doctors at the hospital, referring for blood, speaking to CPN, all the people that were involved in different parts of my grandparents' care for dementia, heart attack, things that I didn't have the knowledge of, that actually needed these professional people to come together and take that pressure off me. The programme actually helped me right away, just having people to talk to acknowledge what needed to happen for me, that I could take that step back but still be the granddaughter that was there to listen and support these things, the changes that were going to come our way. And that's what happened. There were many changes that stepped in for my granddad especially, where there was carers going to come to the house. The pharmacist was going to come and check his medication and put them into a pill box, which took the pressure off me, thinking, okay, what time is it? What pills does he need to have? So that was all arranged for me. I didn't have to do a single thing. And my papa's care actually got so much better. He was happier seeing somebody coming in and talking to him for the morning to give him his meds, during the day for his dinner, and then at night time again for more medication. So he was happy that somebody was coming in, speaking to him while my gran wasn't there until she did come home. So that made him happier as a person. Changing his medication made such an improvement as well. So again, just having these meds evaluated through this programme and speaking to the other doctors that were there helped massively. The programme helped us by the change, the happiness, the change in my granddad's quality of life. Because he was actually so ill, we thought we were going to lose him. And that evaluation process where everybody's coming and speaking together and re-evaluating medication, what was needed, what wasn't needed anymore, because this happened during COVID when people actually weren't able to go to the hospital, they weren't able to go to the doctors, the nurses couldn't see as many people. One of the biggest things that I could see the improvement changing within, I would say, a month. My granddad was so much on his feet, not falling as much, he wasn't as frail.
So as we heard, Tom remained the focus of all the interventions, what mattered to him and what were his hopes for the future. Initially, advocacy was just seen as a resource that could slot into place, but we achieved so much more than what we'd set out to do. Advocacy ensured that the MDT had a human rights-based approach to all the interventions and discussions. But we discovered that we could achieve real health equity, ensuring that the person was able to discuss their health, their concerns and their vision for their future to an independent advocate. The person had a real voice in the MDT, and they helped to shape and guide the interventions. But advocacy also supported the person to recognise that they're experts in their own life, with valuable input and guidance that they can provide the MDT in terms of their health.
Thank you, Lisa. My name is Ana Talbot. I am a consultant in older people's medicine, and it's a pleasure to share this with you. This has really been a team effort. It's about working collaboratively across statutory and voluntary sector, but also about working collaboratively with the pharmacist, the community psychiatric nurse, the community nurse, community rehab team, the home care manager, myself and my primary care colleagues. And without that collaborative approach, we would not have achieved what we have been able to achieve. As we set out to deliver this work, we were interested in the outcome for older people, but also on the wider system. And there were a number of key metrics that we set out to measure. The first was anticipatory care planning rates, and as I'm sure a lot of you know, anticipatory care planning is a way of people recording their wishes around their future health care. And it gives older people autonomy and agency around the choices that they want to make. We had found that in practice one, where we did some really focused anticipatory care planning work, the rates went up very significantly in the severely frail. In the second practice, which already had pre-existing good anticipatory care planning rates, the work on its own, the MDT work on its own, did not shift the numbers that were getting anticipatory care planning. Primary care, as you will probably be aware, in the UK is really, really challenged at the moment with sustainability. Lisa mentioned our area has the lowest number of GPs per head of population, and 1 in 8 practices in Scotland are unsustainable and are handing back their contract to the health board. So we were very clear that we had to understand the impact of this work on primary care. And great thanks to the practice managers who took a lot of time to go through the records and actually manually count the contacts that the individuals we worked with and a control group had 6 months before and 6 months after this intervention. In the first practice, sadly, primary care contacts actually went up after this intervention, and we think that's because they focused largely on those presenting repeatedly who were severely frail. And I think what the intervention did was it uncovered unknown need, and that then resulted in more primary care contacts. The second practice actually focused on those that were escalating to moderate frailty, and actually they did show a reduction in primary care contacts after this intervention as compared to a control group. So that was more encouraging. We also felt that working in this way would shift care from unscheduled care to scheduled care. And so we looked at ED attendances and showed that there was a reduction in ED attendances in the intervention group as compared to the control group. But when we did statistical analysis, that difference was not statistically significant, unfortunately.
We started off the multidisciplinary team meetings with a number of agencies, social work, ambulance service, housing, GPs, consultant geriatrician, pharmacy, physio, you name it, was all round about that table, district nursing. And we started to do an interview with the patients. We did lots of tests of change to see what was the best way to do it. We reviewed the patients' wishes. What did they want? Did it work for them? Was there a better way? So we were interviewing the patients, going out, interviewing them, obviously getting their agreement before we went out, and bringing back to the table with all the professionals what the patient's voice. And the patient's voice had to be the loudest voice in that room, not the GP, not the consultant geriatrician, not the community nurse, the patient's voice and their wishes, because they are the expert in what matters to them. They are the expert in their own life, and they need to maintain control as long as possible.
So that was Liz Kearney, who is a senior health and social work manager in North Lanarkshire, and she was giving her perspective of the value of this work. We strongly believe that collaborating across statutory and voluntary services can allow you to do more at a time of huge resource constraint. But I think even for those of you who are lucky enough to have more resources than us, I think there's real value in collaborating across statutory services and voluntary services, because it really helps to give older people a voice and person-centred care. None of this would have been possible without the team that delivered this, And we are really keen to learn from others, so please get in touch. We're happy to share any resources and the lessons that we've learned. Thank you.
Fantastic, thank you. They are making, all the presenters are making my life very, very easy because they are sticking to the time, which is fantastic. Let me ask if we've got Nav and Baldeo in the room. No? So we've got one presenter missing, so it's not.
Yeah. Yes. Yeah. Oh, I'm here online.
Are you online? Okay.
I'm online. Hi.
Oh, fantastic. Do we have your presentation on?
Oh, yes. It's. I'm on the share screen there.
Yeah, I don't think you can. Oh, you can. Okay, fantastic. Very good. Okay, you've got 10 minutes, Nav. Thank you very much.
Oh, no problem. Thank you, and great to join you all virtually here. I hope everyone can see me and hear me. Maybe a thumbs up, okay? So my name is Nav Baldeo, and I am an upper year PhD candidate at IHPME in the Health Services Organization and Management stream. My doctoral supervisor is Dr. Peter Coit, and I have a committee made up of an orthopedic surgeon, Dr. Raj Ramprasad, an implementation scientist, Dr. Melanie Barwick, and a mixed method specialist, Dr. Farah Ahmad. This project focuses on low back pain at the primary care level, and it is a multi-phased, mixed method study. And I'll be describing some different phases of the research, findings that we've been getting back. So just to go ahead here. I'll go through this very briefly, but really want to take you through the central research questions, some of the theoretical frameworks and methods. And then, of course, we were able to conduct a literature review, the surveys and interviews, which are all now completed. And now moving on to the synthesis, and we can discuss some of the results. So when talking about low back pain and trying to achieve more appropriate care, we really want to understand the primary care factors that increase best practices, use of clinical practice guidelines. Low back pain is highly prevalent, disabling, and costly, as many of you know, and seen all the time in primary care settings. It is the most common problem amongst the working population in high-income countries, and if left untreated, low back pain can lead to significant burden on patients, the health system, and it can include unnecessary healthcare utilization, increased use of drugs, and dependence and adverse outcomes. So evidence does suggest that there is overuse in this area. And of course, some of the key pieces are that it can involve excessive imaging, over-referral to specialist care, and overuse of drug therapy. So the primary research question that we're asking is, what factors amongst primary care physicians and providers that manage low back pain enable or constrain their ability to implement best practices in their care? So really trying to understand the no-do gap. In order to move forward on this work, I drew on the Consolidated Framework for Implementation Research Model. So this is the CFR, and it's possible to identify important barriers and facilitators that affect the uptake of best practices. Traditional, maybe perhaps older frameworks have focused at times too narrowly on provider behavior change, but more recent models such as the CFR recognize that implementation must also consider features of context and setting to have a greater chance of success. So the CFR was informed. It is a meta-analytical framework and informed by other frameworks. And basically, the focus areas are the intervention itself, self-efficacy, and then process pieces, so planning, opinion leaders, and champions. Turning quickly to methods then, this was a mixed method study using a sequential explanatory design. The first phase involved a thematic literature review, followed by surveys that were online, in which we had 240 respondents. Our return rate was about 43%. And the final phase used in-depth interviews with a subset of 21 primary care providers to provide context and better explain patterns in the research findings, some of which I can discuss with you today. So firstly, turning to the literature review, this was a search strategy that was informed by our librarian at Gerstein Library here at the University of Toronto, turning to databases of Medline, Embase, and Cochrane Central to get the North American, European perspectives, as well as review-level evidence. In the end, 76 studies were included, and some of the key themes are in front of you here, which is that evidence is at times difficult to implement in practice. There is divergence from clinical practice guidelines for various reasons, which we can discuss. Multiple barriers actually exist right at the primary care level, hence the focus in primary care. Patient expectations really do need to be centered. Previous presentations drew on this as well. Multiple providers are also needed for low back pain care, and we can talk about the ordering of how they were mentioned. Over-imaging remains a major cost driver. And of course, implementation studies. When you look at the literature, you realize that it's really implementation studies that are needed to close the area. So turning to some of the initial survey results, results of the CFIR survey captured primary care providers' subjective assessment of the relative importance of factors that are known to be important for usage of best practices. Once again, the response rate for the survey was about 43% and featured 240 providers. The CFIR tool itself included domains that had robust internal consistency and relevant domains for analysis. So very briefly, some of the demographic characteristics here are that participants were aged 29 to 76 with an average age of 49. There were about 35% male and 65% female in the sample. Average number of practice years was 18. And our largest training centers were University of Toronto, McMaster, the University of Ottawa, Western, McGill, and Queen's. Then there were about 12% from international schools. And then we had some representation from the north at 17%, and the majority from the south, 83%. And those of you who may know Ontario understand some of the geography. Most of the population is definitely concentrated in the south. So turning then to some of the qualitative findings, since I know time is of the essence here, just wanted to present some of the themes. When it came to the actual CFIR domains, certain factors ended up being very important for the adoption of best practices in care. When looking at intervention characteristics itself, evidence turned out to be the most important for our providers. Whether or not they took that up is another question, but definitely evidence in various forms was most important, and I can give a breakdown of what they turned to for evidence. In the inner setting, the most important factor was ease of access to information, and does this fit into the workflow? For the outer setting, patient's needs was most important, and consideration of the patient's needs. As it relates to individual characteristics, self-efficacy was the most important factor in trying to make sure something is adopted in care. In the process domain, champions, having access to champions, and execution, both were actually the most important factors in that domain. Now, those themes that arose really came up in a more deductive way, since the CFIR was mapped onto the findings. However, the next three were more inductive in nature and came up naturally emergent throughout all of the interviews. And that is that we do see multiple providers that are needed in low back pain care. A virtual care for low back pain, we sort of understand now that half of those who have used it were very happy with virtual care, half had concerns. And finally, we picked up on some general barriers and facilitators to the implementation of best practices as well. So drilling into that with a couple minutes that we have left, for the importance of evidence, people generally agree tools. Specifically, it was up to date. That was the software that was mentioned the most. After this, other providers ended up being the next best source of evidence, followed by academic journals. So that's the evidence domain. With ease of access and workflow fit, once again, those that fit into the workflow will make adoption easier and more likely. But this in particular was very important to try to have that in the EMR, the electronic medical record. So any type of EMR integration will help with that. As we turn to patient needs, patients have a lot of influence in that care encounter. There is room for education, and that education can really help, especially as we talk about imaging preferences when patients show up and have imaging requests. Turning to the other domains, self-efficacy is needed for uptake, and if self-efficacy is not high, actually the provider may not recommend the intervention. As well, champions were found to be very important because they can remind us of initiatives and sustain the intervention. And then execution or codified steps and timelines are very important for sustaining an intervention. With the last three themes, when it comes to multiple providers, really the primary care provider will first turn to other physicians. So that could be specialists, other providers to ask about low back pain or to have consults. Then they will next turn to physiotherapists amongst this group, followed by chiropractors and nurses, and then other providers after that. So finding out the importance and how these other providers are turned to was very important in this work. Finally, with virtual care, once again, half agreed that adoption was great, and low back pain we can use virtual care in low back pain for certain points, but half had concerns about adoption, and particularly in terms of the physical exam and neurological or red flags. So once again, I hope you will turn to the work in the end to see the full findings. And lastly, with barriers and facilitators, key barriers outside of the CFIR were time, training, disruption to practice, and key facilitators were workflow fit, leadership, and size. Some overlap with the CFIR factors to once again reinforce key barriers and facilitators. The synthesis is forthcoming, and this will merge the findings from all of the chapters to make key policy and practice recommendations. We did try to follow a knowledge translation plan throughout this process and consulted with providers along the way. We hope that this will result in stronger application of best practices, greater understanding of modifiable factors, barriers, and facilitators of using best practices, and that it will inform clinical practice as a part of continuing medical education training, coming to relevant conferences such as this and academic meetings, and really hoping that there is an understanding of the importance of using mixed methods in this type of work to understand the what and the why. Some novel points with the use of the virtual care, and really just adding to the CFIR model and understanding that it's the organizational models combined with some of the individual factors that really make a difference in understanding these challenges. Thank you all very much, and hope to disseminate this work even further later. Thank you.
Thank you very much, Nav. Thank you, Nav. Technology sometimes is a bit challenging, but I keep reminding myself that despite the troubles and everything, it's allowing us to be connected with Nav, who is on the other side of the world, and that's fantastic. And we've got, don't go, Nav, stay with us, because we're going to ask some questions at the end, so you might be required. Sarah is the last presentation, and we are moving to caring for love, so for caring for long COVID patients in Belgium primary care. Sarah, it's all yours. I think you've got the next presentation, please. Is it this one? Oh, no, it's this one. Sorry, apologies. Yes, okay.
So hello, I'm Sarah Morsink, and I work as a researcher at the National Institute of Public Health in Belgium, which is called Scienzano, and I work there at the Health Services Research in the Primary Care Unit. So it has been estimated that more than 10% of people that experience an acute COVID-19 infection keep on having persistent symptoms even months after the acute infection. And this is called long COVID. So, and as we also know that during the COVID pandemic, primary healthcare has been challenged a lot. So, and especially general practitioners, they cared for a lot of patients affected by an acute COVID-19 infection, but also general practitioners took up a key position in the vaccination centers, and there was the change of with remote consultations. But general practitioners, after a while, also take up a key position in caring for patients with long-term COVID-19 related symptoms referred to as long COVID. But then, in the beginning of 2022, we noticed that not only in Belgium, but also at the European level, there was little known about diagnostic criteria used by GPs to identify patients with long COVID. Nor was there a widely accepted definition or evidence-based clinical guidelines available for general practice. And also there was little known about the care provided for long COVID patients in primary care. So the aim of our study was to gain insight in the knowledge, the perception, and the experience of general practitioners on long COVID care in Belgium. We made use of a cross-sectional study design. So we used an online questionnaire, which was based on a literature review at the beginning of 2022. And the questionnaire was then later on validated by a panel of experts of the National Institute of Public Health. So the survey was targeting to all Belgian GPs, and the survey was distributed during spring 2022. The questionnaire was first in February and March 2022 distributed to the SGP network, which is a national sentinel general practitioners network all over Belgium. And because we know that in that network there is an overrepresentativity of older male general practitioners, we also distributed the survey to the newsletters of the Belgian GP associations, which are Domus Medica and SSMG, and this was distributed in April and May 2022. The GPs could participate on a voluntary basis, and the questionnaire consisted of 16 ordinal, open-ended and multi-choice questions on long COVID. We also collected information on practice and GP demographic characteristics, but no definition on long COVID was included, as there is a variety in definitions on the post-COVID-19 condition. Then descriptive and logistic regression analyses were performed during this study. In total, we had a response of 105 GPs that responded to our survey, and the GPs were well distributed across all Belgian regions. Also, there was a variety in the type of practices where the GPs belong to, and also we see a good distribution on age of the GPs. So, in fact, the respondents were comparable with all Belgian GPs, except for the GP6, but this is in line with international literature that men are often underrepresented or less answering to online surveys. Then, if we look at the GP's knowledge and perception on long COVID in Belgium, we asked specific questions on GPs, what they say about scientific knowledge and availability on long COVID diagnosis and treatment. So, and we see that the majority of the GPs, it's mainly always
2 on 3 GPs that state that they don't have enough sufficient scientific knowledge on long COVID. The GPs also state that there is a lack of availability of reliable information and research on long COVID diagnosis and treatment. Then if we look at the GP statements on educational material and awareness campaigns for long COVID, we see that the majority of GPs state that there is limited accessible educational material available on long COVID diagnosis and treatment. And also the GPs prefer an awareness raising campaign for themselves, but also for the patients. Then, to assess long COVID in primary healthcare in Belgium, the GPs stated that 60% of them stated that the positive COVID-19 test is a requirement for identifying a patient as a long COVID patient. Also, GPs mainly implemented diagnostic criteria by themselves, and the main criterion for identifying long COVID patients is, of course, the duration of persistent symptoms, which in primary care was identified already from 4 weeks onwards, and that could go until 5 months or even longer. Also, the majority of the GPs stated that long COVID should be considered a chronic disease, and they considered also to suggest their long COVID patients to be inoculated by a COVID-19 vaccine or a booster. Then, when we look at the care for long COVID patients, we see that 75% of the responding GPs reported that they have encountered patients with long COVID symptoms in their practice. And there was no difference between the practice type or the GP's gender or age. Also, when we could estimate a median of 2 long COVID patients per 1,000 active patients per practice. And then on this graph, you can see the long COVID symptoms that were mentioned or the most in primary care in Belgium. So the top 5 is that patients are complaining about general fatigue, concentration problems, difficulty of breathing, and limitation in daily functioning. Also, a lot of half of them complain about brain fog and headaches. When we ask the question to GPs about the care for long COVID patients, almost all GPs state that they prefer a multidisciplinary approach for taking care or for the management of long COVID patients. But then, if we look at the reality in spring 2022 in Belgium, we see that only 33% of the GPs mention that the long COVID patients are followed up by a multidisciplinary cooperation. And also that half of the GPs mention or report that they or GP colleagues solely care for the long COVID patients. Also, when we look at the workload for GPs, we see that GPs are consulted, half of GPs are consulted monthly by long COVID patients, and 18% consults bi-weekly a GP or some months later. Then if other healthcare providers are involved in the care for long COVID patients, or when multidisciplinary care is done, we see that it's mainly the pneumologist and the physiotherapist and the physical medicine and rehabilitation specialists that are involved for the management of those long COVID patients. So, to conclude, in our study, we show that most GPs use, in fact, similar definitions and diagnostic criteria to identify long COVID patients in Belgium, and also that a lot of GPs frequently provide care to long COVID patients, and that GPs take a key role in the multidisciplinary coordination of care for long COVID patients. Of course, at the timing of the study, which was in spring 2022, GPs mentioned that there is a lack of availability of reliable information on long COVID, also that the educational material on long COVID and accessibility to it was limited, and also multidisciplinary care is less organized than preferred by the GPs. Of course, this is around the timing of our study in spring 2022, so I like to add a note to the conclusion, because in Belgium, since the 1st July of 2022 onwards, the government established a care trajectory, which is called post-COVID-19. And in this care trajectory, post-COVID-19 is specified as having symptoms such as fatigue or shortness of breath 12 weeks after an acute COVID-19 infection and or a positive test. And in this care trajectory, long COVID patients in Belgian primary care receive a reimbursement when they have consultations with a physiotherapist or an occupational therapist or a dietitian, a speech therapist, a physiologist or a neurophysiologist. So that's one thing. On the other hand, some months later, in November 2022, there was also an evidence-based guideline published specifically for primary care in Belgium. So based on those two, so on the care trajectory and the evidence-based guideline, the need for information, so more reliable information is available for GPs recently in Belgium, and also those, especially the guideline, this will stimulate the collaboration between the various caregivers in Belgian primary care, especially for long COVID patients. I thank you for your attention.
Thank you very much. This has been very great and very interesting. I would like to be able to also have give the audience opportunities to ask you questions, but I would like to just kind of start with a first question, and that is that it's not absolutely clear to me, and a very brief answer from each one of you, how you deal with the role of the GP. In most of the countries here, with the exception, I think, of Basque Country, GPs are private practitioners with their own private practice. And so it wasn't clear to me, in terms of the innovations that you described, how you engage those GPs. So let's start with our first speaker, who talked about the psychological support. How do you engage the Belgian GP in your program?
Hello?
Yeah.
So of course, my project is about reimbursement of psychological care. So the focus on reimbursement is, in psychologists, but on different levels we involve also other actors, such as general practitioners, who are very important also for detection and early intervention on mental health. And so on the organizational level, they take part, or are part, an important partner in the partnerships of the mental health networks. So there they co-organize and implement a policy. They have their voice alongside of also experts by experience and other actors. And then in the field, there are different levels to integrate GPs. So we inform them, of course, of the offer, that's obvious. But also they can see themselves as this context-embedded places, so where the psychologist goes to offer psychological care within a GP's office or a multidisciplinary practice where the GP is also present. So that really helps for integration of care. GP can also decide to really have a psychologist as an employer, so employ psychologists within their practice, or just collaborate with an independent one. And then there are a lot of things that are done by the networks to bring together these GPs with other actors within the psychological project. They organize evenings or information sessions or days to really make sure that the connection is there. They distribute flyers with the pictures of the psychologists to the GPs so that really the collaboration is intensified. So I hope that was a clear explanation. Thanks.
Yeah. So go on, Alvaro.
Pass it on. Yes.
Yeah, the interprofessional initiatives that were in my study focused on medication plan. And of course, when the different healthcare professionals came together to discuss and to optimize a plan, there was a final, the final step of really change things. Yeah, you need, of course, the approval of the physician, the coordinating physician, or no, the coordinating physician, not the general practitioner. And in the nursing home setting, there are a lot of GPs, and this is, yeah, this was mentioned as a barrier to the interprofessional collaboration, and that's why we are now investigating how important the freedom of choice of a general practitioner is for patients, because, yeah, maybe it's, yeah, we have to compare two situations. So when you have a freedom of choice, or the other option is that you have a more small team with a small number of practitioners in the nursing home, and maybe that works better. But it's, yeah, what we are now going to explore more, because we had limited feedback in our first project of patients. So they were very positive on the pharmaceutical care they received, but not aware of the interprofessional collaboration. They just thought, my medication, yeah, that's my GP, but they were not aware of it. So,
thank you.
For us, GPs were key partners. They were as equal a partner as myself or Lisa or the older person. There is a challenge that you mentioned about primary care sustainability in the UK, and I think for us, I think going forward, we would love there to be additional resource that could go into primary care to support older people, their families, and primary care to continue to provide coordinated, holistic care.
Thank you. Thank you. So why don't you know? Okay.
Yes, so for the long COVID study in Belgium, I think it was clear of my presentation that GPs take a key position in the role for caring for long COVID patients, not only in Belgium, but also internationally. It's really crucial. And I think in Belgium then specifically with the integration of the care trajectory and the evidence-based guideline, a lot of information was distributed to general practitioners. There were also online workshops and information sessions to GPs, which helped them to be more aware of long COVID and how to identify long COVID patients. So yeah, it's a step forward.
Fantastic. Now, yes, if you want to engage with the question.
Thank you, yes. Well, first and foremost, we had to recruit and have physicians be a part of the study, and that was really helped by our rapid access clinic network in Ontario. This was so important to have interdisciplinary members on the team. So our orthopedic surgeon and low back pain specialist, Dr. Raj Ramprasad, had access to this network, and that's how he was able to gain entry and also do this online survey. But in addition to that, this was part of a wider, initiative with the Ontario Ministry of Health and Long-Term Care. There's the Excellent Care for All Act that focuses on low back pain. And now we have Ontario Health Teams where, there is a focus on interdisciplinary care, interprofessional care, all of which the primary care provider, in which most cases is the physician, is the gatekeeper, especially for low back pain. So when we're talking about shared care models or interprofessional care, we're really talking about that central around the GP. And if we are going to act on any of the facilitators, meaning increasing champions, increasing partnerships with physiotherapy, having more EMR integration and virtual care, then this will not only need the GP input, but also we have to really understand behavior settings and the micro and meso levels. So that's all the different ways in which the provider was central to this project.
Yeah, go ahead with the question.
Thank you very much. We have questions coming through the app. So Ala Dayek, she's asking, could you please provide examples of initiatives to maximize physician belief and implementation of integrated care? Examples of initiatives to maximize physician belief and implementation of integrated care. Anybody would like to engage with the question?
Yeah.
They're coming through.
Is that a clear? Just to clarify, I think that most of us experience, and I think Alvaro, we include you in this discussion, that the whole idea of integrated care is a whole new way of thinking. And particularly for GPs that have traditionally in most places been solo practitioners working on their own. And so the idea of doing integrated care is different. So any of you can answer this question, and that is basically how do you have any examples of initiatives to maximize physician belief in integrated care?
I'm happy to talk about that. I think doing small, manageable tests of change and showing GPs the integrated care actually helps them as well as the people that they're there to serve, I think really helps to gain their confidence that this can actually help their workload as well as help older people.
Alvaro wanted to say something?
Yes, well, in Osakidetza healthcare system, there's several initiatives. For example, to my mind came one that is related to the pluripathological patient clinical pathway. So using a clinical pathway, Osakidetza aims to integrate, the whole picture related to healthcare professionals from specialized care, but also primary care in order to provide a continuity of care for those patients in coordination with all the professionals. But also there's a bunch of research projects conducted by other institutions. I know several initiatives from people that are seated there, Indira Coenen, using, for example, technology in order to integrate the service, or to conduct a whole package of the services that can be provided to patients in order to integrate the care that they need for the pathology or the condition that they have.
Okay.
I can make one contribution.
Okay. Please go ahead. Yes, Naf.
One thing that a lot of our providers told us is that when you have that key musculoskeletal or low back pain champion have demonstrations or are able to actually show how the guidelines come into effect. If you have a session, a dedicated session, something that involves a lot of providers, that's where uptake is really high, and that's something that can be continuous because the training for low back pain was not as much in the residency period, and they didn't have much training from before. So key knowledge translation events are good for sustaining as well as with an embedded champion. That was a very good tangible strategy.
Okay, Thank you very much. We're going to
lastly, maybe if I can add also, so I already talked a little bit about integrating on the organizational level, GPs or other physicians, but also on the clinical level, you can integrate them more by disseminating, of course, information, but they're very hard to reach. But also making sure that there is a close link between different practitioners. So the best are, in our experience, still practitioners that are together in the same room or the same building providing care, but also organizing events that they get to know each other, because a personal link seems to be very important still. And then a whole other area is about financial mechanisms that should improve integrated care or collaboration, interventions with physicians and psychologists or totally other actors. Making sure that you have financial means that support that support multidisciplinary collaboration, meetings, and so on.
Very good. Is there any question from the audience that is here? Because we've got questions. Anybody that wants to ask anything? Any burning question up there? Can we only have these microphones here? Okay. So if we can take one microphone just at the back of the room. And in the meantime, very quickly, a question for Indira. How do you reach out to the older isolated persons and their private network who are not open for interprofessional collaboration? How to reach out to older isolated persons? It's a question from Sylvie. How is in the app, how do you reach out to the older isolated persons and their private network who are not open for interprofessional collaboration? So it's how to reach out to those people who are out there.
There were also examples of initiatives that focused on these more vulnerable population of patients, and they were included by the healthcare professionals themselves. So yeah, it was surprisingly like that interprofessional collaboration. So they were not asking for it, but the healthcare professionals included the patients that needed it the most. So that's how they were included.
Right. You did the exercise of reaching out, right? You did the exercise of reaching out.
Yes. Yeah.
Okay. Very good. It's 4 o'clock already, so.
Hi, it's not a question, just thought of sharing our experience as well. I'm from UK, from Rochdale, part of Manchester. It's for the question how we can be more integrated and being a good example. Just thought of sharing, and my name is Satya, and we cover the out-of-hours GP services for Rochdale, part of Manchester, 3 localities, I would say. So we work along with the locality integrated care board, and there are a few examples just to share is how to support the community. There are a few projects which we took it as a pilot and it really went well. One is a reactive fall service. So this is basically focused on the elderly people over 65 when they have a fall and they don't need to wait for the ambulance to attend. So we created a team with all the required skills and knowledges, and they are not clinicians. We upskilled them, and with the support of clinicians, they go and visit the patients who had a fall. This has the, researchers, you all know that the more patient lie on the floor. This project really helped the people to minimize the time they lie on the floor and to avoid the hospital admissions and further A&E attendance. So that's one, and another one we did it along with the, as an integrated pilot is the pulse oximetry service to identify the hypoxia, early hypoxia in patients with COVID or who could be easy to get COVID. So yeah, just thought of sharing. Thank you.
Thank you very much. Any last minute, there are some questions in the app, actually respond to them. So you've got the opportunity to respond. Is there any last minute burning question? We've got coffee now, but if you want to stay for 5 more minutes, we probably can do that. Any questions from the audience that would like to, anybody like to ask? No, then we are going to close this session. Thank you very much, and I hope you've enjoyed this discussion on innovations in primary care. And this is, I think, a topic that we are going to continue discussing for many years in these conferences. Thank you very much. Thank you.
Thank you.
Thanks very much, all.
Thank you, Nav. Thank you. Take care.